Hello and welcome to part 2 of this video. Hopefully you've already seen part 1, which is the theory behind our patient assessment. In this video we're going to be looking at the unconscious patient who is found to be in cardiac arrest. And we're going to work through the scenario as a solo responder and then as a paired responder. Hopefully you'll watch video 3 as well, which will deal with a conscious patient. So let's get started with this. When we first come across any scenario, any situation, the first thing I encourage everyone to do is stop. Stop, think about what you need to do, which is your dynamic risk assessment, and then do it. So as per the JR Calc, the dynamic risk assessment that we're going to look at doing is the scene assessment. So I'm looking for overall safety around, making sure I'm safe. And that may include me putting on my PPE. So depending on the environment, I might need to wear a mask, I might need to wear goggles, and I might need to wear gloves. Remembering good infection prevention, we only put gloves on for bodily fluids, but because this patient is potentially unresponsive, I will need to be doing some airway manoeuvres, so that will count as bodily fluids. I'm not going to wear my mask today so that you guys can hear me, but make sure everything is safe and let's not proceed any further until it is safe. Now we're going to consider the cause. What has caused this patient to be here? It could be another danger, it could be gases, it could be a fall. So work out the cause and make sure it's safe and it's not going to be dangerous for you. Have a look at the environment, thinking about where you are, remembering what the Resus Council teach us, we should create 360-degree access around our patient. In other words, do not start resuscitation if you're in water, a confined space. Get them out, get them to a space, then start your resuscitation, as well as all the other elements we can consider with the environment. Numbers of patients. Do I need to triage? Do I need to work out who is priority? As I've only got one patient, I'm happy to continue. And then I'm looking at the last E, which is extra help or extra resources. Yes, I will need extra resources, and I may even put somebody on standby at this time, just so they're ready for my call, but I need to find out more information about the patient before I do that. So now I've done my scene assessment, I'm happy to proceed towards the patient, and on my way in I'm going to start my primary survey and start talking to my patient. Hello, can you hear me? Hello, it's Jason the medic. Come on, wake up for me. I'm seeing whether my patient's alert. I'm now going through my AVPU. They're obviously not alert, so I may decide to come down onto one knee, nice and close, and give them a verbal command. Open your eyes! Still no response from my patient. I'm now going to tap you on the shoulders gently. I always like to go for the tapping rather than the shaking as quoted in the Resus Council, because with shaking the shoulders there might be potential C-spine injuries which I don't want to make any worse. Because my patient is unresponsive, I'm definitely going to do that shout for help and put my companion on standby because I need to establish if they're breathing or not. At this stage, I'm now going to come all the way to the head of the patient. I could have done my primary survey at the head, but I now need to be looking at their airway specifically. And at this stage, I am going to do my jaw thrust, but I'm not going to lift. So my index fingers around the back of the patient's ears, just to the angles of the jaw so I can support the head. I do not lift at this stage, but I will open the mouth. And when I look inside, if there's bodily fluid, I might need to use postural drainage, and that postural drainage would be rolling the patient away from me and getting good support, my knees right up against their back and holding onto their jaw, allowing for any fluids to come out. Once I think all the fluids are out, I'll bring him back. I'm going to come back around to the head and now I'm happy. If I felt there was a little bit of fluids, this may be when I open up my bag, not forgetting to take out my defibrillator and place that to the left. Open up my bag there. I'm not going to need that equipment, but I am going to use my suction equipment on this occasion. So with my suction, I'm going to put the catheter in as far as I can see, and I can't see any further than that, and I'm going to suck on the way out for 10 to 15 seconds to get out any last bits. Not going to put that back in my bag because it's potentially contaminated. Now I can go back to that jaw thrust position, have another look, nothing in there. I'm now going to lift the jaw. I'm happy that the airway is now open, and I'm going to assess for breathing. So when I assess for breathing, I'm looking for abdominal movement or any chest movement. I'm listening for any sounds of breathing. I could come down lower if I wanted to, but again, I would want to be having my mask on at this time. My patient is not breathing, and as I'm solo, I need to get additional help. If nobody else was around, I may have to get onto my phone, dial 999 and ask for that ambulance, giving them my exact location. If I was working as part of a team, I could get my team to do that. Because I'm solo, I'm now going to get the defibrillator on, and I'm going to have to cut off my clothing to get there. So this is where we always cut from the top, coming down, so we're always cutting away, and on some occasions you can just rip through that clothing. So we're going to go down to bare skin on our patient. We're then going to activate our AED. So we switch our AED on, get that opened up.
Call for help now.
Just going to get the remote control for the AED. We're going to put the pads on, making sure we put these in the correct position. So our pads, one of them will go up to the top, just above the right collarbone. The other pad is going to go mid-axilla, underneath the left breast, underneath the left arm there. Once the pads are on, it will automatically start. While it's analysing, I can get up more equipment, such as my bag, valve and mask, ready. Always pull it out fully.
Everyone clear.
So it wants us to be clear. So clear, top, middle, bottom, oxygen away, shocking. Straight after the shock, I'm going to do over the head chest compressions. And because I'm on my own, I'm going to choose to do 2 minutes of chest compressions, or I could look at doing the 30 to 2. But my partner is now coming into the room, who's going to assist. And because my partner has come in, I'm going to ask them to go straight into the chest compressions. So, while Abby is doing the chest compressions, I can now continue to get my bag, valve and mask set up ready. The oxygen is on and flowing. Placing this over the mouth and nose, I'm going to go for the 2-person technique. Abby will do 2 squeezes, 1, 2, back on the chest, 30 more compressions, and we will now carry on doing 30 to 2. What I'm going to do after the next 2 inflations is have a go at putting some airway adjuncts in. So I'm going to start with my nasal pharyngeal, and then I'm going to go for my oral pharyngeal. So Abby, go to continuous contractions. Let me know if you get to 30 and I'll come back in. So I'm going to go for my nasal pharyngeal, put some lubrication onto the back of my glove. I'm going to go with a size 7 on this patient. We're going to get some lubrication. Keep going, babe, just keep going. And the chafed bit towards the septum, the left nostril going down. That's in. So,
continue care.
Let's get another breath in when you're ready. 1, 2, back on the chest. OPA, so we're going to measure. We've got the right measurements.
Continue care.
Invert, insert, rotate, locate. Okay, I'm back on again.
Not touch.
Okay, so we're going to go for shocking the patient. So we're going to swap positions. So this time Abby will hold on to the BVM.
No shock as I.
So we're not shocking on this one. So I'm straight into chest compressions. So with my chest compressions, I make sure the heel of my hand is in the centre of the chest. I have got my shoulders directly over the heels of my hand, and I am pushing down 5 to 6 centimetres of a rate of 100 to 120 a minute. After 30 compressions, I do 2 ventilations. 1, 2, back on the chest. Keep going. And every 30, I'll do 2 more ventilations. Abby and I will carry on doing this. Every 2 minutes, we will swap positions. We will carry on until either the emergency services come in to take over from us, the patient is obviously breathing, eyes flickering and becoming awake, or we are both completely exhausted and cannot continue. Okay, I'm just going to show you, Abby and I are going to swap positions again.
Continue care.
I'm going to switch the defib off for this little bit. If I was still on my own and Abby hadn't come in, I would then do the single person BVM, and that would be making a C over the mask, an E down the jawline. The most important thing is my middle finger is in the middle of the chin there, and I would hold the mask on, pull the chin back, and I would do my 1, 2 ventilations back on the chest. 28, 29, 30. 1, 2. Back on the chest. And so on. But again, the same procedure would apply. Obviously, I wouldn't be able to change who does chest compressions, but ideally every 2 minutes. What we're going to do in another video is have a look at post-ROS care, such as the recovery position. But for this video, if our patient does have a ROS, return of spontaneous circulation, we would now monitor our patient whilst they're on their back. We would leave the airway adjuncts in, we would put an SpO2 on their finger, we would measure a respiratory rate, take a pulse, and they will stay on their back for at least 10 minutes. We would monitor, record, and then eventually place them in the recovery position. We do hope you've enjoyed this video. Please do tune in for the next one when we look at the conscious patients.